Hi, this week we'll talk about PEEP titration based on transpulmonary pressures. Let's start with a case. We have a recently intubated male with ARDS. We start titrating his PEEP up. We start at 8 and we have a plateau of 24. We go up to 12 and we recheck the plateau. It is at 27. We then go to 16 and our plateau goes to 30. With each up titration, we did an expiratory hold and total PEEP equaled set PEEP. Since volumes were constant in this passive patient, the decrease in driving pressure tells us that his compliance only got better. At a PEEP of 16, though, his plateau is 30 centimeters of water. If we keep increasing his PEEP further, the plateau pressure, our surrogate for end-inspiratory alveolar pressure and our most commonly used marker of safety in mechanical ventilation, will likely go above our goal of less than 30 centimeters of water. Assume we cannot lower tidal volumes any further. What should we do? Increase our PEEP to try to further optimize compliance or maintain the current PEEP to keep a plateau within goal? Since we have no data to support placing higher emphasis in maximizing compliance over keeping plateau pressures less than 30, I would generally favor not increasing PEEP any further in most patients. However, we'll now talk about an important exception: patients with elevated pleural pressures. Let's first remind ourselves of what truly distends an elastic chamber, such as the lungs or a party balloon. What distends these structures is not the pressure inside them, but the transmural pressure, or the pressure inside the chamber minus the pressure outside it. If we want to understand the degree of alveolar distension, we cannot ignore the pressure outside of the lungs, which is the pleural pressure. The same very high plateau may be associated with little alveolar distension if pleural pressures are high, or with significant alveolar distension if pleural pressures are low. Although we certainly should worry about the situation on the right, where we have a high plateau with a high transpulmonary inspiratory pressure, we probably shouldn't worry as much about the same plateau in the setting of a low transpulmonary pressure as you see on the left. In addition, in expiration, pleural pressures may be high enough to be greater than expiratory alveolar pressures, or total PEEP, leading to a pressure gradient that will tend to collapse the lungs on expiration. Therefore, estimating pleural pressures, which we can do with an esophageal pressure monitor, may be helpful, since it allows us to measure the transpulmonary and inspiratory pressure, a more physiologically sound marker of safety of mechanical ventilation than the plateau alone, and also allow us to know the transpulmonary and expiratory pressure, which helps us maintain our total PEEP above pleural pressures. However, a well-designed randomized clinical trial has failed to show benefit in the use of esophageal pressure monitors in the general population of patients with moderate to severe ARDS. It seems reasonable, though, to still estimate pleural pressures in the subset of more severely hypoxic patients when we suspect pleural pressures to be elevated. Elevated pleural pressures are frequently seen in patients with heavy edematous lungs and severe ARDS, particularly in those with poor chest wall compliance, such as those with morbid obesity and those with high intra-abdominal pressures. Let's talk now about the pressure monitor itself. An esophageal pressure monitor is simply a catheter with a balloon that transduces pressures. Ideally, it is placed in the lower thoracic esophagus, posterior to the heart. To place it, we'll typically advance it into the stomach, generally to 60 centimeters, inflate it with the manufacturer's recommended volume, and push on the patient's epigastric area to make sure that it records a rise in pressure higher than airway pressures. This tells us that the balloon likely did not get coiled in the mouth and did not enter the trachea. Once confirmed to be in the stomach, we retract it slowly to somewhere around 35 centimeters to the teeth in most patients until we see conspicuous cardiac oscillations. That tells us that we're probably in the right spot. In passive patients, we proceed with a sternal light push that will show a rise in airway and esophageal pressures of similar amplitude if the balloon is correctly positioned and adequately inflated. Some catheters are radiopaque and allow for radiographic confirmation of placement. Now, let's see some real examples of how to use this tool. The first and easiest measurement to look at is the end-expiratory transpulmonary pressure. We perform an expiratory hold and look for the difference between expiratory pleural pressures and our total PEEP, which is shown in our transpulmonary pressure graph in red. If pleural pressures are higher than our PEEP, like in this case, where the end expiratory pleural pressure is 23 and expiratory alveolar pressure is 18, our total PEEP, then there is an active net pressure of roughly 5 centimeters of water at every expiration compressing the lungs. This is a problem. We would then up-titrate PEEP to get to a goal transpulmonary pressure of -2 to +2 centimeters of water. So there is no net transmural pressure neither collapsing nor distending the lungs prior to the receipt of tidal volumes. An important limitation of this tool is that we're measuring pressures in the pleural space only near the esophagus, which is located somewhat posteriorly in the chest, and therefore dependent on the supine patient. Pleural pressures are heterogeneous though, and certainly pressures in the anterior pleural space are lower in supine patients because the mediastinum and the lungs are not pressing onto that area. This is important because we're looking at a PEEP that is likely optimal for the dependent portions of the lungs, since that is where we're measuring pleural pressures. If we were to shoot for already positive and expiratory transpulmonary pressures near the esophagus, say to +5 centimeters of water, and expiratory transpulmonary pressures in non-dependent alveoli would be even higher, likely leading to significant overdistension even before tidal volume delivery in those areas. Sticking to a goal of -2 to +2 seems to be the safest approach. Now, let's see how we can use the end inspiratory transpulmonary pressure, our true distending pressure of the lungs, as a marker of safety. First, let's talk about goals. While there is robust evidence to support a plateau goal of less than 30 centimeters of water, there is no strong evidence as to what is the ideal transpulmonary and inspiratory pressure. You will find goals of less than 15 to less than 20 reported in the literature. With this in mind, looking at these two cases, while we may be comfortable with the high plateau of 34 in the patient on your left that has an inspiratory transpulmonary pressure of 7, we would not be comfortable in the patient on your right who had a similar plateau but an end inspiratory transpulmonary pressure of 22. This distinction is important because it may change management. For example, on your left, we thought we had to increase our PEEP further, and we were now comfortable to do so despite the high plateau pressure. On the patient on the right, we thought her PEEP was optimal, so the best next step in this case was to actually decrease tidal volumes since the transpulmonary plateau was so high. These two cases highlight how similar area plateau pressures can be associated with remarkably different true distending lung pressures. The difference between these two patients are that in the first, the patient on the left, chest wall compliance was much worse, accounting for a greater proportion of the overall poor mechanics, whereas in the second case on the right, chest wall compliance was just fine, and it was really the lungs that were severely abnormal. To recap, the two main uses of esophageal balloons in ARDS are PEEP titration to an end expiratory transpulmonary pressure of -2 to +2 centimeters of water, and monitoring of safe ventilation, aiming for a transpulmonary plateau of no more than 15 to 20 centimeters of water. That is it for today. I'll see you in the next video.